My name is Lisa Fleming. I work at Highland Hospital in Rochester, New York, and my presentation is an exploration and analysis of health informatics in a healthcare setting. There are three key members of the Health Information Technology team at Highland Hospital. The lead person for Health Information Technology is the Director of Information Technology. The other members of the team include the informatics nurse and the privacy officer. Each team member had their own perspective on job responsibilities and what is required to meet their goals. Even when each member offered individual perspectives, their goals for managing and developing HIT at Highland Hospital are in alignment. The health of an organization's information technology is a shared responsibility. The Director of Information Technology is Jeff DiToro, and Jeff oversees all IT at Highland Hospital, FF Thompson, Highland Family Medicine, and several of the medical and surgical practices connected with UMedicine. There are multiple information systems in place throughout the entire system, and Jeff oversees the operations of these systems and the implementation of new IT systems. He reports to the Chief Information Officer of the entire UR medicine system. The informatics nurse at Highland Hospital is Susan Simeone. Her past experience as both an emergency room nurse and manager are an asset to her current role. Susan is responsible for the coordination of all EMR training for staff. She also assists in all system go-live operations by making sure hospital units are prepared for downtime procedures. Susan is responsible for overseeing the monthly downtime quality checks, which ensure that procedures are in place and active in the event of a system-wide downtime. As if these responsibilities are not enough, she is also a resource and facilitator between hospital clinical areas and the information systems department. The role and responsibilities of the informatics nurse is in alignment with the Institute of Medicine's 2010 report outlining the importance of nurses' involvement in all aspects of information technology solutions for patients. And this includes selection, implementation, and execution. So the next slide, the next role on the HIT ladder is the privacy officer, and her name is Shana Held. She reports to the Director of Quality Management. Her essential functions include performing weekly EMR audits for inappropriate access and providing education for staff and faculty on topics such as how to protect private information and how to avoid inappropriate access. She is also a key player in the development of HIPAA privacy policies for the system. Shana is the primary contact for all privacy questions or concerns. She has a significant role in the oversight of maintenance of privacy and confidentiality of health records. And this is a major responsibility for healthcare institutions. There are multiple operating systems in place within the UR medicine system, and this slide illustrates the major systems used by our healthcare system. There is interoperability among each system, and they are all essential to clinical and administrative operations. Ultimately, an interoperable environment improves the delivery of healthcare by making the right data available at the right time and to the right people. The EMR program for UR Medicine was initiated in 2011 and began at Strong Memorial Hospital. The initial rollout began for the inpatient units, including the ED, OBGYN, pharmacy, and outpatient oncology. In 2011, Highland Hospital inpatient units also went live. And in 2012, Highland Hospital outpatient departments went live. And just as a side note, I was there and I lived through this experience. The EMR system has undergone multiple optimizations since its inception. Workflows have been optimized for ease of use, and an example of this is device integration. This technology pulls the patient's vital signs and cardiac rhythm into the EMR from the bedside monitor. Another upgrade is the sedation navigator, which is now a sedation narrator. And this allows ease of use. The EMR has undergone complete interfacing with all new systems that have been put into place. Computers come in all forms throughout the institution, such as workstation on wheels, laptops, and stationary computers. U of R medicine staff, faculty, and community providers are able to remote into the systems from outside the institution. Personal devices are also in use, but must be encrypted by ISD. The literature notes that when nurses are involved with HIT optimizations and upgrades, nursing standards and scope of practice is enhanced. The EMR has had a significant impact on the delivery of care and patient outcomes, and these impacts have been mainly positive. Along with the EMR came efficiency across the network. When providers input orders, nurses have immediate access to them. Order entry has been optimized with order sets, which allows for error-proof order entry. Safeguards are also built into the system in the form of alert messages and hard stops when the system identifies irregularities in medication orders. Barcode scanning also adds another layer of safety for medication administration. With the inception of the EMR, communication is enhanced between caregivers. Another impact on the way we deliver care is the ability to view everywhere care, and this feature displays health information from care received in other healthcare systems. These are just some of the many examples of how HIT has enhanced patient safety. In summary, patients are receiving their medications in a more efficient manner. Inpatient consults and patient care is expedited. Care is safer and more efficient because of the EMR. Of course, as with any HIT, there are some disadvantages, and they include unexpected downtimes, frozen device screens and keyboards, electronic workflows in need of optimization, and even small changes need to go system-wide. Also, documentation is cumbersome because of the overabundance of nursing flow sheets that need to be filled out. Another drawback in this electronic world is that nobody talks to each other anymore. Even though there are disadvantages related to HIT, the positives far outweigh the negatives. And this is coming from a caregiver who was a laggard when the transition from paper to computer first went into existence. In both nursing and healthcare, meaningful use helps providers make the connection between quality and outcomes. Meaningful use of EMR technology is driven by making care safer, helping people live longer, and making sure making sure care is more coordinated across the care continuum. My healthcare system has met all of the requirements for meaningful use, and the EMR system is attested for meaningful use. My interviews revealed that all government standards have been successfully met for stages 1 and 2 of meaningful use, and the organization has received all funds from the government. Meaningful use stages 1 and 2 are phases of the Meaningful Use Incentive Program that details requirements for the use of the electronic record systems by hospitals and healthcare providers. So, how is confidentiality and privacy maintained across the entire system? My interview with our privacy officer revealed the multiple ways in which patient privacy and confidentiality are maintained. As noted on the screen, there are multiple measures in place to ensure that these measures are maintained throughout the system. So how do we as a healthcare system keep moving forward in optimizing safety and quality? Well, there are multiple technological innovations currently in place within my institution. One of these is the adoption of device integration. And this technology allows nurses to focus on their visual
patient assessments and decrease the amount of time spent documenting. And this is crucial in critical care area settings. This innovation began with a simple question: can vital sign information flow from the bedside monitor to the EMR? Of course, this implementation took some time, but once put in place, it has improved workflow efficiencies and enhanced patient safety across the system. There is a second technological innovation that will soon be implemented, and this breaking news was revealed to me during my interview with our informatics nurse. Soon technology will be implemented to allow data from IV pumps to flow into the patient's EMR. This innovation will enhance care delivery and has a positive impact on nursing care. IV fluid consumptions will be accurate and available in real time. This workflow will alleviate the need for nurses to manually input IV data into the patient's EMR. Another advantage is that other caregivers will have immediate access to this information, and this direct flow of data will enhance patient safety. The bottom line is that nurses will have more time to spend with their patients. Innovation 3 is in my very own unit. We now have automated technology that allows us to track the multiple steps involved in managing our endoscopes. Before the automated endoscope tracking system was available, nurses and technicians had to manually record data for scope reprocessing. This was very time-consuming and operator-dependent. The current technology in place has the capability to scan each scope into a system's database. The scope is scanned when used, reprocessed for disinfection, stored, and when sent out for repair. This has enhanced patient safety in the endoscopy unit, since now we are able to quickly identify a scope and patient if there is any break in any process. In the past, it took a significant amount of time to manually collect data. This technology has advanced safe practices in the endoscopy unit. The fourth, but by far not the final innovation in technology available to nursing is the implementation of automated work lists. The work list is generated from orders that are entered into the patient's chart. Optimization of the work list generates a pop-up in the EMR, and the nurse is prompted with an alert. An example of this is work list duties are generated on specific days when tasks need to be carried out. Another example is when a patient needs a flu shot. An alert will show up on the work list each day until it is either accepted or declined. And this innovation keeps the nurse on track for patient needs, which lead to positive patient outcomes. So what does it all mean? The emergence of technology in the field of healthcare has changed the way nurses deliver care. The EMR unifies and coordinates care delivery by creating a single patient-centered health record that serves the entire network. The EMR's capabilities puts all providers on the same screen while caring for a patient. It also allows for amassing important information such as allergies, med lists, and test results, and physician notes. This technology allows caregivers to provide safer, more efficient care. There are also multiple safeguards in place to make HIT safe, as well as keep patient information confidential. As with any technological system, there are advantages and disadvantages. However, the advantages far outweigh the disadvantages. Technology is changing at a rapid pace, and constant growth and optimization is a must. When caregivers know better, they do better. Looking back on this course and this project, I feel that I have increased my knowledge on how the impact of HIT has changed our workflows. I was one of the skeptics during the electronic transformation, and I felt anxious and incompetent with this new technology. However, over the last few years, I have adapted to the change, have even become an expert in this technology. Through this project, I learned about the responsibilities of the informatics nurse and that she is the central contact when HIT challenges occur. I have come to the realization that HIT is interwoven into everything that nurses do. Nurses have the responsibility to remain competent and informed, as do nurse leaders and administrators. Nurse leaders cannot support and advocate for staff if they do not know what they are supporting and advocating for.